Right, welcome to this video on bronchitis and emphysema. The main focus of the talk will be on chronic bronchitis and emphysema, which is the conditions that we tend to see in hospitals, the so-called chronic obstructive airways diseases. But let's start off with a bit of orientation and look at the anatomy so we're getting the terminology right and we know what part of the respiratory tract we're talking about. So obviously the main airway is the trachea, held open by these 3/4 complete rings of cartilage to keep it open. You probably remember if you're looking at it from the top, they're 3/4 complete rings like that, maybe slightly less than that. And the reason for that is the esophagus is immediately behind it, so it allows boluses of food down. But the rings of cartilage maintain the patency of the airway, which of course is absolutely vital that the airway lumen is maintained to allow air to go in and out of the lungs. Now going down, of course, we divide into the right and left main bronchus. So here we see the right main bronchus, and still with its rings of cartilage to keep it open. And of course, immediately this starts branching into what we call the bronchial tree. But if we follow one hypothetical branch of the bronchus down, of course there'll be many branches coming off, going to all of the areas or the alveoli in the lungs. And these smaller bronchioles here are referred to as a segmental bronchus. The reason it's segmental is it goes to a segment of lung tissue. So a segmental bronchus. And then going down further still, we come to the bronchioles or the small airways. So a bronchus is a large airway, a bronchiole is a small airway. And round about here, I've drawn a line across here because this is really where we go from the macroscopic level. You can actually see this. And below here it's difficult to see because we're getting to a much smaller scale. We're coming on to the microscopic level. And here in the terminal bronchioles, which go into the airways, into the air sacs rather, there's no rings of cartilage anymore. So the terminal bronchioles go down to the actual respiratory bronchioles, and the alveoli branch off from the respiratory bronchioles. So that's the nature of the airways that we're going to be talking about. So we're going to start off our study by looking at acute respiratory conditions, and we're going to start off with acute bronchitis. Now acute bronchitis is just what it says. It's an acute, that means it started recently, inflammation of the bronchial tree. So an acute inflammation of the bronchial tree, acute bronchitis. Now very often these begin as viral infections, and often they just get better if the person's otherwise healthy. But they can go on and you can develop bacterial secondary infections after an acute viral infection. But we're talking about the acute conditions that a person will suffer from and hopefully completely resolve. So let's think about this condition, acute bronchitis. So as we've said, often begins as a viral infection. And typically, initially, there's a cough because of the irritation to the bronchial tree, but it's often unproductive. And it becomes productive later on as the infection, as it were, starts to clear out from the lungs. And quite a lot of mucus can be coughed up later on in the infection. And if there's yellow or green sputum, which there very often is, then this indicates the presence of bacterial infection. Yellow or green sputum indicates bacterial secondary infection. Very often there's an uncomfortable feeling behind the sternum due to coughing and due to the infection itself, and a general tight feeling in the chest. Now remember, the air is going in and out of the bronchial tree through inflamed passages. Therefore there's more mucus and things in those passages. Therefore there tends to be some obstruction. So there can be wheezing as the air gets past the obstructions in the bronchial tree. Of course, because the lungs are involved and the person's ill anyway, there'll be shortness of breath. And of course, whenever anyone has got an acute infection, they shouldn't exercise anyway. There may be mild fever because of the infecting viruses and bacteria. And typically this is a self-limiting condition. In otherwise healthy adults, the condition resolves in about a week normally. And bronchitis is fairly common in childhood, after any childhood infection such as measles or whooping cough or typhoid. And of course, a bit of bronchitis for most children, they will recover from it fairly quickly. But if you go into conditions where there's a lot of poverty or nutrition is poor or living conditions are poor, then a lot of the children do have a degree of bronchial infection for much of the time. So in healthy children, the conditions tend to resolve quickly, but other intercurrent infections or living conditions in children that are in any way immunocompromised because of, for example, malnutrition, then bronchitis can become quite a severe problem. And of course, if it's bad, it can go on and infect the lung tissue itself, which we would refer to as pneumonia. So we've looked at acute bronchitis. Let's just think about children now. And it's a sobering thought to realise that perhaps chest infections are the most common single cause of death in children in the world. Now, this depends on the age group of children you're looking at. In very young children, it would be diarrhoea that's the most common cause. But simple chest infections kill an awful lot of children. So this means we need to be on the lookout for them, prevent them if possible, of course, and treat them fairly seriously and give antibiotics when it's appropriate. So what are the factors involved in predisposing children to bronchitis and these chest infections, these potential life-threatening conditions? Nutrition. If the child is malnourished, then they're going to be immunocompromised. To have good immunity, you need to be well nourished. Other concurrent infections are going to predispose to bronchitis. It seems that the body is only good at fighting one infection at a time. If there's other infections in other places, then chest infections become more likely. In overcrowded conditions, the children spend a lot of time breathing in other people's pathogens, breathing in bacteria that have been breathed out by other people, transmitted by droplet infections. And in the same way, if the living conditions are poor, especially if it's damp, and the child's inhaling water vapour into the lungs a lot of the time, again, bacteria can adhere to the water vapour and cause infections. So bronchitis in children, just like in adults, it often starts with a viral infection, and the RSV virus, the respiratory syncytial virus, is the most common in young children. But bronchitis in children over the age of 6, if it's clinical, is more likely to be of the bacterial type. Therefore, antibiotics should be considered. Just as with the adults, the cough can be unproductive initially and becomes productive after 2 or 3 days. And if the child's otherwise healthy, they will recover, again, in 5 to 10 days, in a week or so, providing that their nutrition is adequate, there's no concurrent infections, and it's not exacerbated by overcrowding and other poor living conditions. So let's think about treatment of bronchitis in children, or indeed any acute bronchitis. Well, antibiotics work very well against bacterial infection. Typically, amoxicillin 250 milligrams 3 times a day will be an adult dose. Amoxicillin works quite well against most types of bacteria that infect the bronchial tree. There's many others that can be used. Aspirin and paracetamol might make the person feel better if there's a pyrexial component. Analgesics, if the chest is bothering them, if there's pain, can be considered. Humidity can sometimes help because the water vapour and the very fine water vapour in humid air can keep the secretions mobile and therefore allow them to be expectorated. And of course, all sick people should rest. And in children, bronchiolitis, infection of the very small airways, can occur. This is quite a serious condition. And sometimes hand-to-nose transmission of a virus can give fairly big outbreaks of this. and children are usually under 2 years of age. But potentially quite a serious condition. I mean, in very simple terms, I think of this as a form of childhood pneumonia, really. So acute chest infections, for most of us, inconvenient, you don't feel very well, but recovery should be complete. Now what I want to focus on this talk really is the chronic airways diseases. Chronic bronchitis, chronic emphysema, what we tend to call chronic obstructive airways diseases. Now bronchitis is literally inflammation of the bronchial passages, and emphysema is destruction of the alveoli. And these two usually go together. In fact, you could say they always go together to some degree. So bronchitis and emphysema. We call these chronic obstructive airways diseases. Not a particularly good term, really. The best term really is chronic bronchitis and emphysema. That describes what it is. So various, and let's look at the notes, chronic bronchitis and emphysema. Now, I've heard these called chronic obstructive airways diseases, which is the term I must say I do tend to use. I've also heard them chronic obstructive pulmonary disease, COPDs. I'm not quite sure what the difference is. No one's ever explained it to me satisfactorily. And I've heard them called COLD, chronic obstructive lung disease. So take your pick. But the best term really, chronic bronchitis and emphysema. It describes quite precisely what we're talking about. And in a patient with the chronic airways disease, both conditions, that is bronchitis and emphysema, coexist in each patient to various degrees. Now some patients might be primarily bronchitic, others might be primarily emphysematous, but they'll both have some bronchitis and emphysema if they've got one. And this results in airflow limitation. That's the key thing. Airflow in and out of the lung becomes limited. Now, of course, there are other conditions in which this occurs. For example, asthma. I've actually used the term AOAD here. I don't really think many people use this. I've made it up, I think. But it stands for acute obstructive airways disease, because that explains what asthma is. It is an acute obstructive airways disease. So in asthma, there's obstruction to the airway, because in asthma, you might remember, the main features are you get bronchoconstriction, the bronchioles get smaller, so less air can get in and out of the lungs. You get inflammation, so that swells the inside of the air passages, and you also get excessive secretions, which tends to clog them up a bit. So you certainly get airflow restriction in asthma. In fact, to a life-threatening degree, you can get it. But it's acute, it's an acute obstructive airways disease, and it's reversible. Whereas with the chronic one, there's damage to the lungs and the condition is there all the time to a varying degree. But with chronic obstructive airways diseases, you can get acute exacerbations. So very often in hospital, someone will be admitted with chronic bronchitis and emphysema with an acute exacerbation of the condition. This means that yes, they have chronic bronchitis and emphysema, but they've had a bacterial infection which is overlaid on that and can make them quite ill. So we're talking about chronic, not acute, obstructive airways disease. Let's define our terms. It's always useful to do that. Bronchitis, what we mean by bronchitis is a productive cough on most days for 3 months of the year for more than 1 year. So if for 2 years running, for at least 3 months of that year, someone has a productive cough, then that is chronic bronchitis. So the definition is a symptomatic one, really. It's describing the amount of cough, the amount of product produced, and the amount of time the cough is suffered from. Emphysema, on the other hand, has a more pathological diagnosis, definition rather. It's abnormal permanent enlargement of the air spaces. Abnormal permanent enlargement of the air spaces due to destruction of the alveolar wall. Let's have a look at a few diagrams and try and explain what we mean now by the term emphysema. Now here we see some normal alveoli, the air sacs, where gaseous exchange takes place, and the respiratory bronchioles. And of course the key thing is that the alveoli are infolded sacs, and this gives a large surface area over which gaseous exchange can take place. But if there's a loss in the air sacs due to destruction of the alveolar walls, then I think you can see that here there is less surface area than here. And if this happened again to another one, imagine another air sac there, and this wall was lost as well, then we've got even less surface area. So we're getting, as we said, abnormal but permanent enlargements of the air spaces, reducing the surface area over which gaseous exchange can occur. So in a normal lung section, which we've looked at in other videos and we'll probably look at again later on this one, we see lots of alveoli. If you section a lung microscopically, magnified by 500 or 600 times, you'll see that there's lots of air spaces here, and in these walls there'll be capillaries to facilitate gaseous exchange. So you have a large, spongy, elastic lung. But in the emphysematous section, then the alveoli is lost, the surface area is lost, the elasticity is lost, and of course the whole ability of the lung to carry out gaseous exchange is reduced. So here we see an emphysematous section of lung, and what we can actually see here is we can actually see air spaces. These are gaps with just air in them. And here on a macroscopic level. Now you certainly should be able to see air spaces in the lung, but only when you magnified it by about 500 times. So there's actually a lot of space here in the lung that shouldn't be here. Massive reduction in the surface area due to this enlargement of the air spaces due to destruction of the alveolar wall. And here we can see all this lung is very emphysematous. You can actually see the air spaces quite clearly. The normal lung, you couldn't see them without magnifying it several hundred times. So here we see another emphysematous lung. Large air spaces. And as we look down on this section specimen, then I think you can see here that the air spaces have become absolutely huge. Very, very severe emphysema, extending all over the bottom of the lung. So literally big caverns in the lung here with complete loss of alveoli. So we've considered the nature of emphysema. Let's now consider the nature of bronchitis. Now in bronchitis there's infection and inflammation in the bronchial trees, in the bronchial passages. This has an inflammatory response, and it means that if this happens repeatedly and there's repeated inflammation and resolution, then you start to get fibrosis and scar tissue and thickening of the lining of the bronchial passages. And it's this which gives rise to the restricted amount of air that can get in and out of the bronchial passages. And this can become very severe, almost completely obstructing some bronchial tubes. So let's think about a normal bronchial passage first, looking at insection. And the key thing to notice is the lumen in the middle. That's all this space in here. all this is lumen to allow air in and out. So large normal lumen. On the specimen below, which is of the same size, on the section below, then this is fibrous tissue here, which has accumulated in the lumen due to chronic, repeated infections, repeated inflammation, and resolution with scarring. And of course, once this fibrous tissue is deposited in here and the scarring begins, then it means that the surface is irregular and infection can occur more easily and expectoration of mucus becomes more difficult, resulting in stasis. So the whole thing can be a bit of a vicious downward spiral. So an obstructed bronchial lumen, as occurs in chronic bronchitis. Now here we see an X-ray of someone with chronic bronchitis and emphysema. And the first thing to notice is that there's a lot of air in the lungs. The patient is unable to breathe out. The lung fields are very dark, meaning there's a lot of air in them. And the diaphragm's low. The diaphragm's flattened because the lungs are overexpanded. And in fact, the lungs are a good couple of ribs lower than you would normally see. Normally the diaphragm will be fairly well domed up like that. So lung fields are a couple of ribs lower than you would expect in a healthy lung with a flattened diaphragm. So the lungs are overinflated and blackened. And the reason this patient actually came in, sorry, not literally blackened, they're blackened on the X-ray because there's a lot of air in them. And the reason this patient came in, we can actually see down here, there's a left lower patchy consolidation here. The lung tissue to some degree has been made solid by infection. And I think you can see around about this area there's evidence of fluid in the lung tissue and consolidation. So what's happened here is that there's a patient with chronic obstructive airways disease, chronic bronchitis and emphysema, and they've had an acute exacerbation in the form of patchy consolidation in the left lower lobe. So I've mentioned that bronchitis and emphysema go together, and we'll see why this is later on. But some patients traditionally have been referred to as emphysematous and some bronchitic. In other words, some patients seem to have more emphysema than bronchitis, and others seem to have more bronchitis than emphysema. And there is some clinical application to this knowledge. And the patients that are mostly emphysematous are referred to as pink and puffing. They tend to be pink coloured and they puff and pant. And patients with bronchitis tend to be blue, i.e. cyanosed, and bloated. That means they retain fluid. And again, we'll see why these are. So these are the classic clinical types you might come across. Type A, referred to as pink and puffing. These patients are breathless. And because they're able to puff and pant a lot, they can blow out most of the carbon dioxide. And because they're breathing a lot, because they're puffing and panting, they can compensate for the lack of surface area in the alveoli to a degree. So traditionally in a patient that's pink and puffing, the arterial O2 and CO2 are relatively normal. In these patients, Cor Pulmonal, which we'll study in a minute, would not be a major feature. And in this case, the patients will be predominantly emphysematous with little bronchitis. So the pink and puffing type. The second type, the type B, are referred to as the blue and bloated type. And these patients are cyanosed and they are edematous, blue and bloated. They tend not to be as breathless as the pink and puffing type, but the arterial oxygen is low and the carbon dioxide is high. And this clinical type occurs predominantly in bronchitis where there's little emphysema. Now, having said that about the two types, the pathology that's actually found doesn't relate very well to the clinical picture, but there is some clinical application to it. And most patients are a combination of the two types. In other words, bronchitis and emphysema go together to give what we call chronic obstructive airways disease. Let's think about how common these conditions are. Well, in the UK, very common. About 17% of men in the age range 40 to 64 have some bronchitis and emphysema. So pretty common, nearly 1 in 5 there. In women it's less due to the fact that women smoke less or traditionally have smoked less, and it's about 8% in the 40 to 64 year age range. And this condition seems to be becoming less common in the developed countries because to some extent atmospheric conditions have improved, or well, the atmospheric conditions are actually bad. But those that seem to particularly cause bronchitis and emphysema have improved. But the main reason probably is people are smoking less. But in developing countries, where there's increasing amounts of air pollution, especially in the cities, and where there's more smoking, then bronchitis and emphysema is becoming more common. It's also fairly common in developing countries where people are forced to burn fires in the house to cook on and to keep themselves warm. In Nepal, for example, where a lot of people are forced to cook on open wood fires because they can't afford any alternative, then for years and years people are breathing in a lot of smoke in their houses, and they get this chronic bronchitis which can lead on to emphysema as well. So becoming less common in developed countries, but becoming more common in many two-thirds world countries. So increasing prevalence in many developing countries, decreasing in the UK. And it's an important condition because especially in thinking about developing countries, it carries a considerable socio-economic burden. In other words, the people that are suffering from this condition should be economically productive people. They should be going out, planting the crops, working in the factories, bringing up the children, doing all the work that needs to be done, but they can't do it effectively because they've got bronchitis and emphysema. So it's a very important disease for us to prevent. People shouldn't smoke and shouldn't spend any amount of time in smoky environments. We must advise people against this because it's the inhalation of smoke that's maybe the main cause, in fact is the main cause, of bronchitis and emphysema. Let's go on and think about the clinical features of the condition now. Features of bronchitis and emphysema. Well, bronchitis, an acute or chronic inflammation of the mucous membrane of the tracheobronchial tree. In other words, it can affect all of the bronchial tree. So thinking about bronchitis now specifically, let's just get this clear. We're talking about bronchitis particularly. We're not talking about the features of emphysema very much. So features of bronchitis. We'll come on and look at the features of emphysema later on. So bronchitis, an acute or chronic inflammation of the mucous membrane of the tracheobronchial tree. And as we've said very often, this becomes chronic to give chronic bronchitis. One of the key features of chronic bronchitis is a very slow, insidious onset. Maybe over many, many years the cough will become progressively worse. So the patients don't realise they're getting worse very often. And it's only when someone like yourself actually sees them and says, just a minute, you've got a bad cough, and you can actually realise then that they are developing chronic bronchitis. So insidious onset. And this is why people often don't take measures to stop. You can listen to smokers with the most appalling cough. But for them, it's normal. You know, they don't realise this is abnormal. And it's only when they compare themselves to maybe to what they were 20 years ago that they realise there's a difference. So slow onset over often many years. So insidious development of a persistent cough, one of the features of bronchitis. Wheezing and shortness of breath, and progressive shortness of breath on exertion. And one thing you very often see people with chronic bronchitis doing is the exhale like this. This is called purse string lip. Purse string lip. It's like a purse string, tight. And the reason people with bronchitis do this is because it produces more back pressure in the lungs when they're breathing out like this, and that helps them to exhale the air. Whereas exhaling with the mouth open, they find it more difficult. So purse string lips, sometimes a feature of chronic bronchitis. One to look out for in your patients. Purse string lips on expiration. Now, thick, excessive gelatinous sputum associated with hypertrophy of the mucous glands. So thick, difficult to clear sputum, very characteristic, produced by hypertrophy of mucous glands lining the bronchial tree. And as well as hypertrophy of the mucous glands, you get increased number of goblet cells producing more mucus. So more mucus is increased number of cells, meaning you get a lot of mucus. And this excessive mucus impairs ciliary movement. So remember, normally the cilia are wafting up the mucus into the trachea where it can be coughed up. But if it's all clogged up with this very thick gelatinous sputum, it can't move, so it can't clear. So the gelatinous sputum decreases the mobility of the cilia, and when the cilia can't waft properly, it means you get stasis of the mucus, and of course that leads on to infection. So increased number of goblet cells, thick excessive gelatinous sputum, that impairs ciliary movement. The impaired ciliary movement means that there's mucus stasis of the mucus, and of course when there's stasis and that mucus is not being cleared, that leads on to infection. And of course the infection causes irritation. The irritation causes excessive production of gelatinous sputum, and the whole thing goes on. It's a bit of a vicious circle. Now, mucus stasis and infection can lead on to plugging of some of the smaller airways. In other words, if there's a division in the bronchial tree here, say, and there's excessive amounts of mucus in this one, and it dries up, it can actually plug off this whole thing here. So there can be mucus plugging of some smaller airways. When it's more severe, the bronchioles will be very inflamed, and there can even be pus in severe bronchitis, purulent bronchitis. And the severe infection can lead to ulceration, and of course the ulceration will be followed by healing, but in the healing there'll be excessive production of fibrous scar tissue. So the ulceration can lead to fibrosis. As we've seen in the diagram, the fibrosis narrows the lumen, and narrowed lumen leads to airflow limitation, which of course is one of the main features of the chronic obstructive airways disease. After a while, the cilia can actually be lost completely, meaning that there's a chronic inability to clear the mucus from the airways. And an important point, initially small airway inflammation is reversible if the smoking or the insult stops. So someone who's developing a smoker's cough, if they stop smoking, if they get out of the smoking environment, the lungs can recover. If they carry on, they're going to become a chronic obstructive airways disease sufferer with chronic bronchitis and emphysema. But very important to stress, in the early stages, this is reversible, and in fact there's benefit stopping smoking or getting away from the smoking environment at any stage in the evolution of the illness. But early on, virtually completely reversible. So well worthwhile people stopping smoking. Exacerbations occur. We've talked about exacerbations of chronic. So acute infections superimposed on chronic bronchitis and emphysema. Very often these occur in winter when it's colder, because cold air causes bronchoconstriction, stops the cilia working properly, because the bronchoconstriction even more restricts air entry and exiting the alveoli, and it also restricts the lumen still further, making clearing of the bronchioles even more difficult. And chronic bronchitis often progresses to emphysema. Obstruction of the bronchioles may lead to distending alveoli, which may aid in the breakdown of the wall of the alveoli themselves. Now, this is perhaps not the main pathogenesis in emphysema, but it does very often seem to be the case. We'll look at what the main pathogenesis is later on. So we've considered the features of bronchitis. The last feature we're going to consider is that there might be right ventricular failure or cor pulmonale. And what we'll do now is look at right ventricular failure or cor pulmonale. So we're going to think about this feature, cor pulmonale. Now, cor pulmonale is pulmonary artery hypertension. The pressure in the pulmonary artery is increased, and that can lead on to right-sided heart failure. So cor pulmonale is heart failure secondary to lung disease. Now, when the lung is diseased, the amount of oxygen in the alveoli will drop, because it's used up, but you can't breathe the air in and out very well, and even though the lung was overinflated, the quality of that air is low. It's got too much carbon dioxide and not enough oxygen. Now, when the amount of oxygen in the alveoli is low, that causes localized vasoconstriction. So there'll be less blood supply to that area. Now, presumably the reason for this is so that more blood will be left over for healthy areas of the lung, to maximize the amount of oxygen the blood can collect as it goes through the lung. But if the amount of oxygen is low all over the lungs, then you'll get global, all over the lungs there'll be vasoconstriction of the pulmonary artery. And that'll mean that there'll be increased resistance in the pulmonary artery. And of course, blood pressure equals cardiac output times peripheral resistance. So, in other words, the pressure in the pulmonary artery will increase secondary to low levels of oxygen in the alveoli. If the pressure in the pulmonary artery increases, it means the left ventricle has to work harder in order to pump blood into it. So you've increased the workload of the right ventricle. If that becomes chronic, then there'll be right ventricular hypertrophy. It'll grow in size, the muscle will grow in size, resulting in a cardiomegaly. But if that goes on even longer, hypertrophy will ultimately result in failure. So the left ventricle will fail. If the left ventricle fails, it means it can't eject the blood which is in it properly. So it means the blood coming into the right ventricle from the atria won't be able to get in. The atria won't be able to empty. The blood won't be able to get into the right ventricle from the right atria. So the blood's going to dam back, as it were, into the right atria. And of course, that means that the blood draining into the right atria from the inferior and superior vena cava won't be able to get in either. And you can see that's going to dam back throughout the entire systemic venous system, and it's actually going to increase the pressure in the systemic blood system capillaries. So there's going to be increased pressure in the capillaries. The increased pressure in the capillaries is going to reduce the amount of tissue fluid which is reabsorbed from the tissues, because there'll be hydrostatic pressure opposing its re-entry. And that means that fluid will collect in the tissues, so there's going to be edema. So cor pulmonale then, heart failure secondary to lung failure, resulting in systemic edema. That's where we got the blue and bloated part from. Well, we haven't got the blue part, that's where we get the bloated part from. So let's run through that on the notes. It might not make sense yet. Then we'll look at it in a diagram, and then hopefully it will make sense. So normal pulmonary arterial pressure, about 25 over 8 millimetres of mercury, as opposed to about 120 over 80 in the systemic circulation. But due to chronic bronchitis and emphysema, there is reduced oxygen in the air spaces. This results in localised pulmonary arterial vasoconstriction through poorly oxygenated areas, because there's no point sending lots of blood to areas which are poorly oxygenated. That sort of makes sense. So in the normal circumstance, it would mean that blood is left over for the better oxygenated areas, and you're optimising the oxygenation of blood as it passes through the lungs. So in the normal circumstance, it would mean that blood flow is matched to alveolar oxygenation, which is what you would want. But of course, this is not a normal situation. This is a disease situation. It's an abnormal pathological situation. And the oxygen, the amount of oxygen in the lungs will be low all over the lungs. So if the level of oxygen is low all over the lungs, then there'll be vasoconstriction and increased arterial pressure all over the pulmonary arterial tree. So pulmonary arterial pressure will rise, and pulmonary hypertension is Cor Pulmonale, or the start of Cor Pulmonale. What about the blue part? We've said these patients can be blue and bloated. Well, the blue part is caused by cyanosis. And cyanosis is caused by lack of oxygen in the red cells. So as the red cells pass through the lungs, they're not picking up enough oxygen, so you get cyanosed tissues. But as well as that, because the amount of oxygen in the blood is low, that stimulates the production of erythropoietin from the kidney, from the juxtagamillar apparatus in the kidney. And that stimulates the bone marrow to produce more red blood cells. So these patients are relatively polycythemic, and maybe that's the main thing that causes the cyanosis. An increase in the amount of the red blood cells in the circulatory system. So that accounts for the blue part as well, the polycythemia and the hypoxia. The bloated part is secondary to edema, secondary to right heart failure, and the right heart failure, as we've said, causes this systemic edema. Now, if you watched other videos, we had a basic diagram of the circulatory system, and I'm going to draw that now fairly quickly. If you want to learn how to draw a diagram stage by stage, you'll have to watch the first video on the circulatory system. But it should explain why you get the systemic edema when secondary to lung disease, the Cor Pulmonale part, the heart failure. So, in a heart, we have the septum, the valves, semilunar valves there, and the atrioventricular valves there. A very crude diagram, of course. The aorta coming out here, going to the body, circulating all parts of the body. From this side we have the pulmonary artery going to the lungs. This, of course, vena cava returning to the right side of the heart. What have we got here? Now that will be the right atria.